All right. If I could have the members of the panel come on up. We have some questions that we'd like to have them address. Just to sort of follow up on the population health issue, for those of you who don't know, Brenau just started another MBA track in data analytics. So all those pretty pictures that Dr. Rio showed you on the screen, that's essentially data analytics. So, you know, we pull the information off of the health information exchanges, and it doesn't matter whether it's Longstreet or the hospital or your private practice doc, cluster that all together and give them information that they can use in their clinical practice. That's data analytics, and there's a specialty field quickly developing, especially in the healthcare industry, for data analytics. Yeah, do we have any more questions? I've got some up here. If you have any, just, yeah, we'll take some questions. All right. So here's one regarding the Cadillac tax. Okay, on the Cadillac tax, does this apply to all employee benefits or strictly to health and prescription insurance premiums?
Is that sorry, repeat that. We're over here fixing this.
Oh, sorry. Okay. Regarding the Cadillac tax. Yeah. Okay. Does this apply to all employee benefits or strictly to health and prescription insurance premiums?
The health and prescription premiums.
Right. So if you give people, you know, education benefits,
right,
you don't get hit with the other benefits that you provide to your
Correct.
employees. Okay. We pay the cost of the first 3 months of COBRA coverage for our employees who were laid off. Will that prevent them from buying coverage on the marketplace after the subsidized period has ended? Okay? So you're paying the first 3 months of COBRA after you lay somebody off.
If an employee elects COBRA at any point, then they've had their chance for their qualifying event, and if they elect COBRA and they end up dropping COBRA, they would not be eligible for a subsidy or would not be able to go through the marketplace. They'd have to wait till open enrollment or until COBRA has been exhausted.
Okay, so clear to everybody?
Because there's a lot of people that think
Right.
that you can take COBRA for 1 month, maybe because you have something that's ongoing. You might take it for the month of September. If you drop that, that's not another qualifying event to then get an individual policy in October. You'd have to wait till January 1 of 2016 to start that plan, or 2017 if it was.
Okay. What is the employer penalty for not offering coverage in 2015 and 2016? So you're electing not to offer coverage.
The index cost went up to $2,080. It's broken up over 12 months, so it'd be 1/12 of multiplied. Every month would be multiplied by your population. Subtract the first 80 this year on a large employer segment, and next year that will be, you only subtract the first 30 full-time employees. So it's $2,080 after the first 80 this year and 30 employees next year in 2016. Right, yeah, this is just, 50 plus, 2 to 49.
50 plus.
You don't have to offer coverage, so there's no penalty there.
No penalty under 50, correct. Yeah. Okay, this is for the docs. Many people point to diabetes, obesity, blood pressure as standard examples of conditions we could and should be managing better in our patient populations. You know, there's also, you know, pharmaceutical implications here. What are some of the less well-known items you feel will need to be doing a better part of managing? So in addition to the things we always read about, you know, in the paper, what are some other things that are floating around we need to watch for?
I think that we are definitely looking into asthma. As you know, there's still many deaths related to asthma, believe it or not. COPD, chronic obstructive pulmonary disease, which is one of the most common complications of tobacco utilization. So those are things that we're looking at. Of course, heart disease is still on the top of the list, high cholesterol, blockages in the arteries of the heart. And many of those things, Jeff we had talked about it, you know, the environment, the responsibility we all have to remain physically active, manage our weight, diet, etc.
I would also add there's opportunity for the appropriate interval of routine testing for things in well patients. Whether we are missing screening tests that should be done or are over screening people. And I think some of that comes down to patient education in terms of appropriate intervals for screening. Again, I use that example of mammography. You know, who needs it and how often do they need it? Same thing with colonoscopies, vaccinations, and other bone densities and things of that nature.
Is it still your impression that obesity drives a lot of these other clinical conditions?
Absolutely.
Okay.
One of the things, too, that the physicians Jeff mentioned it in his talk, are learning a lot more about is the cost of different decision points. And that is a difficult conversation with a group of physicians in an area that, you know, they would make recommendations for follow-up care or treatment options or even refer patients after hours for certain things to the emergency room or other places. And now we're having dialogue not only about the quality of outcomes from those clinical areas, but actually looking at their cost drivers. What are their costs per thousands of going to the ED and inpatient? How is that different from you know, their peers, and learning and having a dialogue around those cost factors, which physicians typically are not as well versed as you might think that they are in those kinds of aspects of patients' care.
Just one more thing to add. Location of care. You know, Antonio and I were talking about this. Most of the way we deliver medicine is very physician-centric. It's during my hours. It's not necessarily during the hours which are, you know, most beneficial to other people. So you're starting to see some of the primary care offices be open during what we call, or what I refer to as family hours, evenings, weekends. And so I think you'll start to see also, as Mimi alluded to, the location of care. The ER is the most expensive place, so if we can get people, you know, care in an office setting at 7:30 at night for their headache or their respiratory symptoms, it's far more preferable than to a higher cost center. So I think you'll see expansion of hours and availability of care as well.
Mimi, this is for you. What is the impact of increased Medicaid enrollees on the provider community? I didn't write it, sorry.
Well, you know, the state chose not to expand Medicaid, and wherever you sit on that subject politically, we won't have to debate. But, you know, there has been the impact of increased enrollment just as a bleed over of the economic factors that go into Medicaid enrollment. We have not really seen in Gainesville, I think Dr. Rios would agree with this, a significant increase in the Medicaid practices in business that we have in our practices. It has stayed fairly consistent with the growth in the community. We still see about the same percentage of babies delivered and women delivering babies in the Medicaid program. And we continue to see a significant population of patients without any insurance. And I think that's really kind of still the nut to be cracked, and how are we as a community and as a state going to deal with the truly uninsured and underinsured, because that continues to be a factor in the marketplace given the fact that the state chose not to expand Medicaid. We're very fortunate, as you all know, to have great resources and a very collaborative community between Good News Clinics, the health department primary care clinic that's staffed by Northeast Georgia Physician Group, the prenatal program that is run by the Longstreet Clinic and the health department, Health Access Initiative, and just a really caring, compassionate community. We do a really good job with the uninsured and underinsured, and so we're fortunate for that. But it is a cost that falls to the system and to the healthcare providers and ultimately to the community.
Okay, Leah, just to follow, what we do know about Medicaid expansion came out of Oregon, where Oregon piloted Medicaid expansion early on. And what we have seen with new enrollees to Medicaid, those people who did not have Medicaid and then were given Medicaid, initially there was a spike in what? They did what they had always been doing. And what is that?
Visit.
Going
Go
to
to
the
the ER.
emergency room, right, for their health care. right? Now, that has plateaued last year, but what we're still seeing is people who have Medicaid using the healthcare system and still at an increased level when this is a randomized controlled trial when compared to non-new Medicaid enrollees.
In Massachusetts, too, they had that same impact with not only the Medicaid population, but with that, increase in eligibility and the provider community not being equipped to take on new providers, new patients. And so, again, I think they're seeing that in some parts of the state. I think our community, again, is very fortunate in that we've got lots of investment in physician and manpower support, and the practices are continuing to grow to meet the need. So there's capacity capability within most of the physician practices in the community. So we're fortunate, but we're not like the rest of the state.
Right, thanks. Brett, this may be for you. Who educates people to make their healthcare decisions? The physicians, the docs? Who wants to take a crack at that?
Make their healthcare decisions?
That's what it says. Who educates people to make their healthcare decisions?
Yeah. Hopefully their doctor, but in regards to the plan, I mean, if they're going out to a broker, there's a lot of independent brokers in our area, specialize in both individual and group. So, you need to do a full analysis of what would be best for you.
Right, and I guess, there's the healthcare navigators. I guess UGA is out of that business, but there are still healthcare navigators to help folks navigate the Affordable Care Act, or the exchange plans.
Correct, yeah. The only issue with that, and I mean, it's a great resource, but you need to make sure that you're referencing, as we talked about with Georgia having the most narrow networks of any of the companies, that you're not just signing up for a plan because it's the best price. If the doctor are not in network or the hospital's not in network, then the plan's no benefit to you. So.
And within the healthcare community, Dr. Rios mentioned care managers. Again, something that's happening in our world is a reinvestment in RNs and LPNs in those care manager roles, not just within the hospital setting. We've all had case managers and that kind of activity in the hospital, but within the physician practices. So all of the practices in Gainesville pretty much have invested in those resources, and those resources are a great place to, if you have an employee that has multiple medical problems, doesn't seem to know how to navigate what's going on with their health care, to see if their physician practice has a care manager or care coordinator and get them connected. The practices are really trying to identify those people and partnering with them and their families to help them navigate their health care needs.
Steve, this is for you. Can you give us more information on how someone can get assistance with the cost of specialty drugs?
There's several different places, and the one mitigating factor to it is what your payer will allow. Some payers don't allow pharmacies to utilize copay assistance cards. Believe it or not, the easiest place to find copay assistance cards, and I'll give two of them, one less obvious than the other. First place is the internet. Believe it or not, if you just type in the name of a drug, the first thing that's going to show up is a copay card and how to use it and how to enroll in it. And those can be easily printed and taken to pretty much any pharmacy for use. A lot of the specialists have them actually in their office. It's probably the only place left really that pharmaceutical manufacturers can actually talk to physicians about specific drugs, how they're supposed to be used, and in coordination of that, provide different alternatives for patient assistance. They're widely available. Originally, copay cards were used to kind of offset formulary preferred drugs and non-preferred drugs. That whole concept's pretty much gone away. Almost any brand name drug that you can name, you can find a copay card that'll help patients pay for the cost of the drugs.
Okay, thanks. Do you know, when we talk about pharmacy, we usually talk about big numbers. Do you know, and this is sort of, you may not know this off the top of your head, but how much it costs to develop a drug from bench to animal to phase 1, phase 2, phase 3 clinical trials? Do you, just a ballpark figure?
A very ballpark figure would be $1.2 billion.
Correct, yeah. So it's a lot of money to get a drug through the FDA approval process and out on the market.
Pretty much in today's market, it's it's almost a 1 to 10 relationship. So for 10 entities that are being developed, and remember in my presentation I said there are 900 of them that were in some phase. Probably 90 of those will actually make it to market, and all of them will cost, if they cut short, probably $750 million. If they get to market, probably $1.2 billion.
Correct.
And then they have to make it back.
Yeah, those are the figures that I had heard. Okay, we have a couple more questions. If employers purchase insurance products that use the Health Partners Network, do they get the benefits of the clinical integration efforts the physician spoke about?
Steve's not up here.
Where do you go?
Ultimately, that's clearly our goal, is that through these efforts that we're doing, we help drive down the cost for the plans that are using the Health Partners Network. It's not it is not a narrow network. It's not an exclusive network. It's HB2, as the slide showed earlier, is a subset that's leading the effort, but the entire Health Partners Network is involved and will be included on those contracts. So we ultimately want to make this scalable across all the practices that are involved in Health Partners, but with working with these core groups to begin the facilitation of that process.
Okay. One more question after this. Someone asked, will we get a copy or email containing this information? Just so you know, we are videotaping this, and after, today we will edit the videotape. We will put it on Brenau's YouTube channel, and we'll work with Kit out of the chamber to blast everybody who attended an email so that they can hit the channel and they can see all of the presentations with all the references, et cetera, et cetera. So, you'll have a copy of all the information. Last question. Who benefits from the fees that are paid for not having insurance?
Not me.
Not you. I think those go into the general revenue stream, don't they, from the Affordable Care Act? I think those are just dumped back.
I'll give you a classic case example. We have a client in Louisiana who started out as a health plan on the exchange, and their expectations of how things were going to proceed was that they were going to be paid some money by the government and the rest would come out of premiums. Unfortunately, because of the delays in how the ACA was actually released and how it's been impacted, there wasn't enough tax money around for them to actually get the incentives to get the premiums. So what they wound up with is they wound up with a whole bunch of sick people and no healthy people. And in effect, they're going to shut their doors at the end of this year. To get back specifically to the question, they were expecting, because the penalties were going to be in place, they expected healthy people to want to take insurance to pay the premiums so that they can continue in business. They were relying, and I don't know exactly what the percentages were, they were relying on the government for some money, premium from unhealthy people for some, premiums for healthy people for some, and tax penalty credits that were collected in Louisiana for the penalties for not having non-insurance. So
Right.
that's kind of the scenario that they were looking at.
Yeah, I think the
Didn't work out.
CBO numbers that they used in their assumptions were you had to have 40% healthy young people enroll, and it's in the mid-20s last I saw.
Right. Louisiana actually has 84%, last we had heard,
Yeah.
of patients that were critically using their system.
Okay. All right, let's give the panel a round of applause. Thank you all. And then I will turn the microphone back over to Kit.
I'll be very brief. I know you're ready to get out of half a day. I want to thank you for your attention, and thank you again, Mimi and Dr. Reinhardt, Dr. Reyes, Brett, and Steve for answering all these questions. If you have other questions individually, if you'll get them to me or individually to them, we'll get them answered for you. And if you'd like a hard copy of the presentation or something sent to you, then let us know. I do want to thank quickly just our sponsors one more time: Brenau University, Turner Wood & Smith Insurance, Northeast Georgia Health System, ProCare RX, Rushton & Company, and your own chamber. thank you so very much for coming today. I've learned a lot, and I've learned a lot that I don't know. Thank you. Good deal.